Hi, I'm your host, Dr. Chuck Murphy. Welcome to Inova Talk. We're streaming live from the Inova Fairfax Medical Campus in Falls Church, Virginia. February is American Heart Month, and we're doing a series of heart health-related shows this month with Inova physicians to highlight heart and vascular issues. Inova Heart and Vascular Institute is a leader in providing care to patients with heart and vascular problems. We have 5 Inova hospitals where this care is delivered, including a dedicated heart hospital, which is on the campus of the Inova Fairfax Medical Center. In addition, we have a large network of outpatient facilities where patients are able to see cardiologists, electrophysiologists, pulmonologists, and surgeons. In addition, there is a network of vascular and cardiac diagnostic imaging facilities located across Northern Virginia. Today we're going to be talking about raising awareness of heart valve disease. I want to remind people to please post your questions in the comments section, and we'll try to answer them live. And always keep in mind that this is for informational purposes only and is not meant to replace the advice you get from your physician. Joining me today is interventional cardiologist Dr. Matt Sherwood and heart surgeon Dr. Eric Sarin. Dr. Sherwood and Dr. Sarin, can you take a few minutes and introduce yourselves?
Sure, thanks Chuck. It's nice to be here with you. I'm Matthew Sherwood. I'm the co-director of the structural heart program here at Inova Heart and Vascular Institute. I'm an interventional cardiologist, which means I do procedures through catheters to try to help people's heart, both for their coronary arteries and their valvular heart disease.
Okay, my name is Eric Sarin. I'm a cardiothoracic surgeon here at the Inova Heart and Vascular Institute, and along with Dr. Sherwood, I'm the co-director for the structural heart and valve disease program. My primary clinical interest is valvular heart disease. So with Matt, we work on innovative transcatheter approaches to valve disease, and I'm also the primary mitral valve surgeon for our institution.
Great. Well, February 22nd was annual Heart Valve Disease Awareness Day. And so this final Inova talks during this Heart Month is going to be focused on heart valve disease. Let's just get right into this. Now, sometimes patients find out they have valve disease when they go to a physician and a murmur is heard. And so, Matt, maybe you could talk about, if in that situation where the person is not having any symptoms at all, but all of a sudden they've got heart valve disease, what that sort of looks like.
I think there's a really important point, Chuck, and that is most people with heart valve disease don't have a lot of symptoms until it becomes severe. And so what we ask those patients is we're going to follow them closely every year and sometimes every 6 months to evaluate their heart valve disease and then to look for symptoms as they can develop while the valve disease gets more severe. So it's really important, even if you have a heart murmur or mild or moderate heart valve disease, that you continue with regular follow-up with your primary care physician and your cardiologist so that we can monitor the progress of that disease and then choose to evaluate for symptoms and possibly intervene at the right time.
And that's such a key point, because intervening at the right time is so important, because you could wait too long and allow for permanent heart damage to occur if you waited way too long to intervene.
You're absolutely right, and what we want to do is kind of find the sweet spot. Typically, it's when patients have just started to develop symptoms that indicate that the heart valve that's not working very well is having some kind of effect on the heart or the body. And at that time, we can choose, with Dr. Sarin's help, the right kind of intervention, whether it be a transcatheter intervention or a surgical intervention that will help get people back to their normal state of health.
Okay. And Dr. Sarin, let's move to specifically aortic valve disease, that valve that leads out of the heart to the rest of the body. What type of symptoms do people get when there's a more severe issue?
Yeah, so as Matt said, one of the hard things about valvular heart disease is that the symptoms are very subtle in the beginning, and they increase slowly over time. And so one thing, just to backtrack, and I want to echo what Matt said, is that when someone gets a new diagnosis of a murmur, I think it's really important that that gets followed up on. Especially if it's a new diagnosis later in life for someone who's been seeing a physician regularly or who hasn't seen one in many years. And if for no other reason, just to get a baseline echocardiogram of what your heart function looks like. Just because you have a murmur doesn't mean you're going to need surgery or some intervention, but it gives us a baseline, to look at going forward. So I think that's really important. I think, as you talked about, what happens is for people as aortic stenosis progresses, people will find that they're getting more shortness of breath, more fatigued, more tired. The end stage, presentation of congestive heart failure or kind of, syncope, where you faint because you're not getting enough blood flow, across that valve. Those are really the kinds of symptoms we want to avoid. And so the hard part is if you're feeling short of breath and fatigued and you don't have another good explanation for it, it's important to follow up with your primary care doctor, and at the very least, have them listen to your heart, because if you have a murmur, it's something we want to intervene on sooner rather than later.
And when you do develop the symptoms of the severe aortic stenosis, so someone is starting to have heart failure or the syncope episodes, how does that tie into the timing of procedures?
Yeah, so we consider those symptoms as kind of the cardinal symptoms that you've really started to approach the end stage of that disease. So syncope, fainting, heart failure symptoms, or pain related to inadequate flow down your coronary arteries. When you have those symptoms, you have about a 50-50 chance of mortality in about 2 years. And so at that point, the horse isn't necessarily out of the barn, but we certainly need to be moving quickly.
Now, truly, over the last several years, I'm sort of a dinosaur myself, so I used to have to open patients up to replace that aortic valve, but I think maybe this truly revolutionary advance is the transcatheter aortic valve replacements. And Matt, maybe you could tell us some about how that has been sort of a revolutionary advance.
Absolutely. So in the last 10 years, it's changed from all the patients that I had who had severe aortic stenosis. I would have to send to Dr. Sarin or a cardiothoracic surgeon to have open heart surgery. But now, in the last 10 years, we've been able to revolutionize a technology called transcatheter aortic valve replacement. And that is replacing the aortic valve through a catheter that most of the time goes through your leg. That allows us to replace the aortic valve in a probably 45-minute to 60-minute procedure. It allows patients to not have to undergo general anesthesia for that procedure. And you only have to be in the hospital for 1 or 2 days and can go home and recover and really be back to yourself within 1 or 2 weeks, which is very different than an open heart surgical procedure. So, I think of it, and other experts have said it's probably one of the most important medical advances in the past 20 years.
I think that's absolutely right. It's definitely a huge advance, but I also want to make sure that we're recognizing surgery for the intervention that it is. And surgical aortic valve replacement has been the gold standard for decades. Patients tolerate it very, very well. It is proven to be life-saving. So if you see someone either at our institution or another institution and they're recommending a surgical aortic valve replacement for whatever reason, you're still going to get all those results in terms of improved quality of life and improved survival that Matt alluded to. But there's no doubt that Tavor has revolutionized that ability to get a comparable surgical result in a much shorter period of time.
And for example, if somebody has a ballooned aorta or an aneurysm, that sometimes they would require surgery to go repair or replace the valve as well as do the aneurysm.
And certainly, if someone who is on the lower risk, category comes in with aortic valve disease, but they also have coronary disease, they would benefit from bypasses, or as you talked about, a concomitant aneurysm of the ascending aorta. The nice part about these decisions is that they're made with a multidisciplinary team. So, we're making those decisions with an interventional cardiologist, a cardiac surgeon, imaging specialist, heart failure specialist. So we're bringing the best minds to bear for each particular patient to make sure we're coming up with the best treatment strategy for their particular disease.
And I just want to echo what Eric said. I think it's so important that you go to a place that has a heart team and can offer you the wide breadth of aortic valve disease kind of treatments. And we get together and we talk about what the best thing would be for each patient. So it's really important. Some patients, Eric's completely right, would be best served with an open heart surgery, and some patients would be best served with transcatheter aortic valve replacement. And what you want is a thoughtful group of physicians trying to give you the absolute best care that they can. And it may be one of those two or maybe something different.
Yeah, I think that stressing the team-based approach is so important. Maybe I think one of the other things that I think would be an important selection point was the volume that the center is doing. Do you want to tackle that?
I think when you look at any kind of surgical intervention, you always see usually an increase in the outcomes when the volume goes up, and we've certainly been no stranger to that here. Our program has grown rapidly in the last 5 years, and I think Matt would probably agree with me. I take a lot of pride in obviously the growth of the program, but I take even more pride in the fact that we've been able to maintain our outcomes in the top 10% of the programs in the country. So we're doing a lot more of them, but we're also doing them safer than the vast majority of other programs.
And so now the patient has had the aortic valve replacement. What type of follow-up will the patient require after that?
So it's really important whether they have a transcatheter procedure or they have an open surgical procedure. It's important that they follow up with the heart valve disease team, and that may be a surgical appointment or an appointment with our valve clinic, and that's a specialized clinic that we have here at Inova that takes care of patients with valvular heart disease and takes care of making sure that they have the appropriate follow-up. In addition, anytime you have a valvular procedure, you're going to have to follow up with your cardiologist at least once a year, checking on that heart valve, whether it's surgical or transcatheter, getting another echocardiogram, usually on a yearly basis, making sure that it's functioning, and following it over time. Because in the future, if you're young, you may have to have another heart valve procedure, and we want to do that at the right time as well.
And right after the procedure, is there a indication for having some sort of cardiac rehab? Do we send those patients to rehab at all, or?
Yeah, so absolutely. For both transcatheter aortic valve replacement and open heart surgery, cardiac rehab is indicated, and we should definitely have our patients participating in cardiac rehab. So through our valve clinic, every single patient that gets a transcatheter aortic valve replacement is referred to cardiac rehab at the time that's right for them. So typically that's within 2 to 4 weeks after the procedure. We make sure that the patient ready and is able, and we go forward.
I think maybe one other thing to mention about the transcatheter valve replacements, and again, a strength of our program, is related to the fact that some patients will have blockages in the arteries in their legs, and it may require a different approach. Maybe you could comment on that.
Yeah, so as the technology's improved, we're at a point now where over 90% of our cases we're able to do them safely transfemorally. So the cases you're talking about, when that sort of subset of patients that have bad peripheral vascular disease, or for some reason we can't safely go through the groin, we have to use an alternative access approach. And for us, we're fortunate here that because of our high volume, we've been able to maintain a very active practice with alternative access approaches. Typically, we're using the carotid artery or the subclavian artery. We're very proud of the fact that those patients are pretty much on the same pathway. We're still looking at discharging within 24 to 48 hours. The outcomes are comparable. I think any program that's going to be effective at treating all comers has to be able to manage those sort of tricky access issues.
And then, in addition, now we're talking about transcatheter aortic valve procedures. Could you comment on tackling other valves, such as the tricuspid valve or
Sure.
the mitral valve, which are the valves between the upper and the lower chambers of the heart, and what we have available there?
Sure. So there's obviously a lot of excitement in the field around valvular heart disease, just because of the performance of Tavor, which has really just been amazing to watch. As Matt said, I agree. It's one of the biggest advances in cardiovascular medicine in the last 50 years, if not in the history of cardiovascular disease. So naturally, there's going to be a lot of excitement about tackling other valves, the mitral valve or the tricuspid valve. And already, billions of dollars have been put into those spaces. What people have found out relatively quickly, though, is that the aortic valve for aortic stenosis is a relatively straightforward disease process to treat. I mean, it was almost tailor-made for a catheter-based approach. The mitral valve and the tricuspid valve, there's a lot more nuance there. So there is definitely progress being made, and we're proud to be a part of a couple novel clinical trials now looking at new technology. We also have an active Mitral Clip program, which is a transcatheter mitral valve repair technology, the only one that's FDA approved here in the United States. But I think it's going to be a long time coming before we sort of have the same impact in the transcatheter space for mitral and tricuspid valve disease that we do with Tavor right now. I think it'll get there, but in the mitral valve, when we talk about repairing a mitral valve, we're often employing 4, 5, 6 different techniques at a given surgical time. At a given surgical intervention. I think what you're going to see in time is that you're going to have catheter-based techniques that mimic each of those techniques that are then employed sort of sequentially. So the nice part about a catheter approach, you can bring someone in, do one intervention, see how they do, bring them back 3 to 6 months. If they're still having issues, do that second intervention and go from there.
Maybe just talk a little bit more about the Mitral Clip procedure, and what that entails. And I believe that we're very fortunate to have some of the real experts in the field available here as well.
Yeah, Matt, you want to?
Sure, absolutely. So I think it's actually really important to emphasize just what Eric Sarin was saying, and that is that the standard for mitral valve kind of treatment is honestly surgery. And that provides you the best possible results typically. But for those patients that may not be the best candidates for surgery, then we do have transcatheter options that can help them. And one of them is the Mitral Clip. It's really a really elegant procedure that's done through the vein in the leg, actually going through the structures of the heart, and then putting a clip on the two mitral valve leaflets to try to reduce the amount of leakage. It's been shown in certain patients both to improve quality of life, but also to improve their lifespan as well. And I think it's really, really important for those patients that may not be great surgical candidates. It's an incredible breakthrough to be able to offer them a procedure, because before all we could offer them was medical therapy. We are also fortunate to have one of our colleagues, Wayne Batcher, here, who's honestly one of the world experts with Mitral Clip. And so it's been really, really nice to do those procedures and have an expert like him available to us. But I don't want to lessen how important it is to have an expert mitral surgeon here at Inova, because I think that differentiates us, having a world-class expert in Mitral Clip, having a world-class expert in mitral surgery. That means that whoever comes into the doors, we can not only choose the right therapy for them, but then provide it.
Yeah, and I'd like to dive into this mitral valve disease a little bit more. So Dr. Sarin, in terms of when symptoms from mitral valve disease, what typically does that look like in terms of symptoms that patients get?
Yeah, so it's a lot like aortic stenosis in the sense that it'll start simply with some fatigue, some shortness of breath. Oftentimes, patients will come to me, when they finally got a diagnosis with an echocardiogram, and they'll have a history of recurrent pneumonias. Well, those recurrent pneumonias were actually heart failure, and they get admitted in heart failure, and they have an infiltrate, or it looks like an infiltrate, which is really just failure collecting in their lungs. So it can mimic and mask a lot of different things, and that's why I think it's important that as physicians, obviously, when we're doing exams, we're listening to people's hearts. But for patients who've been told they have a murmur, that's something that they always have to be thinking about if they start having symptoms or they're in the hospital. To ask their physicians, could this be related to my heart murmur, or is it worth getting an echocardiogram?
And again, the timing of interventions is extremely important.
The timing's important, and so historically, we've had criteria for years and years that we looked at, when we talk about is someone asymptomatic or not, and that was often a trigger for surgical intervention. And specifically when it comes to mitral valve disease, especially since this tends to skew a little bit younger, especially when we're talking about degenerative mitral valve disease, where there's an actual problem with the leaflets themselves. And so you really, if you're going to send that person to surgery, you want to make sure it can be done with a very high degree of safety. So you need to have a mortality rate that's less than 1%, and a very high rate of success when it comes to repairing the valve. And so, because of Inova's long history with valvular heart disease, I'm proud to report that we rank in the top of the country when it comes to both of those two metrics. And so, with that in mind, when you look at the criteria that talks about waiting till people develop symptoms or the evidence of left ventricular volume overload or atrial fibrillation, as a surgeon, I would encourage people to refer sooner rather than later, because if you start waiting for those symptoms to happen, you're potentially setting people up to be missed in the long term.
And if 100 patients come in and need to have their valve taken care of, how many of those would actually end up walking out with a repair generally?
So it depends on the disease type, and so it's important for patients to understand that there are two main families of mitral valve regurgitation when we talk about it. We're talking about degenerative disease in general, and I think for degenerative disease patients, typically your repair rate should be well above 90%, which is what ours is here at Inova.
Okay. And then again, but occasionally someone, to get that perfect result for them, may end up not being able to have a repair.
Yeah, may not have a repair, and they may be better served with a replacement in the long term. And I think that's where having an institutional experience matters. When you have a program where people have been doing this at a very high volume for years and years, you actually, an experienced mitral valve surgeon will know before he ever, or she ever puts the knife on the patient's skin, whether or not that's going to be a more challenging valve to repair, or they're more likely to come out with a replacement. And for me, typically, if I see those situations coming, that's a discussion I'm going to have with the patient ahead of time.
Matt, are there any sort of family genetic kind of issues related to valve disease?
I think that's really interesting. There are some valvular diseases that are what we call congenital or related to your genetics. The most common one, and probably one of the most common genetic diseases in all of cardiovascular medicine, is something called bicuspid aortic valve, and that is where the aortic valve typically has 3 moving leaflets, only has 2. And so those patients, we look for that, and if you have a family member that has a bicuspid aortic valve, then it's reasonable to have the first-degree relatives, that is the mother, father, siblings, or children of that family member, screened at an earlier time with an echocardiogram to make sure that they don't also have a bicuspid aortic valve. That's the most common one. There are other cardiac abnormalities that can run in families, but I think in terms of talking with the general public, that's the one that I would emphasize most.
Okay, and that's a program we also have here at Inova.
That's right. We have a strong aortic program for aortopathy. One of our surgeons, Liam Ryan, is the director of aortic surgery program for those patients who have aortic aneurysms. Just related to bicuspid aortic valve, you're much more likely to have an aortic aneurysm if you have a bicuspid valve. And so thankfully at Inova, we have experts for all of those medical conditions so that we can treat patients in the best way. But I happen to see a lot of those patients on the kind of medical side. And so really important if you're diagnosed with an aortic aneurysm is to follow it, because the timing of intervention in that case is also very important. So we follow an aortic aneurysm over time to see, as it grows slowly, when we should do surgery for that condition.
We have a couple of questions, so I want to dive into those. One of our viewers asks, what is the durability of the Tavor valve? Dr. Sarin, maybe I can...
Yeah, so that's a great question. And so, if you look back, we don't have the same, decades upon decades experience of Tavor yet that we've had with surgical valves. But the materials, by and large, are the same that we use to make a Tavor valve versus the surgical aortic valves. And so, in all the early studies we've done so far, starting in the higher risk patients, moving to intermediate risk, and now in low risk, there hasn't been any real true statistical signal that's shown us to expect anything different in terms of durability. So typically, if we're seeing a Tavor patient in a mid-70s patient, I typically tell them the same thing I would tell a surgical patient, which is we should expect at least 12 to 15 years of durability out of that valve. The important thing to remember about surgical valve replacements, and this will be important as we start getting into lower risk and younger Tavor patients, is that when the patients are younger, valves won't last as long because the wear and tear is just enhanced when you're more physically active.
But it's worth maybe mentioning that if they did need a secondary procedure, they potentially could have another valve. Yeah,
so the concept of valve in valve it's been great for, we've used it routinely now for patients who have a surgical valve, a previous tissue valve placed that then they've gotten their 12 or 15 years out of it, and that valve is degenerated as we would expect it would. To be able to put a new valve inside them without having to open their chest up and go through all the scar tissue, I think has really been a huge advance. I think it's important for patients to understand, though, that in terms of in the realm of putting a Tavor valve in first and a second Tavor valve in that, or even a third Tavor valve in that, that's pretty uncharted territory. And so, as Matt said, when you're counseling a young patient and they're choosing their treatment strategy going forward, they have to understand that a Tavor and tissue valves may set them up for multiple interventions over the course of their lifetime.
Okay. Matt, here's a question. Non-surgical ways to improve heart valve health for women, diet, exercise, vitamins. Maybe you can say what can be done about heart valve health, and then maybe more broadly how people can help their heart health.
Absolutely. So heart valve health is a little bit different than overall cardiovascular health. There aren't that many medications or other things that you can do to prevent heart valve disease, but I think actually it's really important to emphasize that you should lead a healthy lifestyle, try to eat the right foods, try to get regular exercise, etc., to improve your overall cardiovascular health. Because if you do have a valvular heart problem, we're going to be looking for all the other things that could happen to your heart, coronary artery disease or other issues, heart failure, and those will impact how we treat your heart valve disease. So overall, I would recommend a generally healthy, heart-healthy lifestyle.
Okay, great, thank you. Another question here is, these are great questions, and I'm going to throw this one at Dr. Sarin. Is it possible to do 2 transcatheter valves during the same surgical procedure to the aortic and mitral valves? Can we do double valve replacements yet, Dr. Sarin?
So it becomes nuanced because it depends on what the pathology is. We have certainly done it here where we've had patients who have had a history of 2 prior valve replacements, so they have a tissue valve in the aortic and the mitral position, and both of those valves are ready in terms of having worn out, they're ready to be replaced, where we have in the same setting replaced both the aortic and the mitral valve, and that's gone quite well. If you're talking about de novo disease, meaning that you've never had an intervention before and you have, whether it's aortic stenosis or aortic insufficiency, mitral valve regurgitation, or mitral valve stenosis, then it's important that you become evaluated because the pathology that is affecting each particular valve really matters.
And maybe a question for both of you all, the most promising developments that you see coming down the road within these spaces.
Yeah, I think it's really exciting. I think we've gone further and further with transcatheter aortic valve replacement, and now we're really kind of perfecting it, getting the best possible valves, getting the best possible procedures. But that really has come a long way in the past 10 years. And just as Eric said earlier, I mean, it's really important to think about, can we do just as good a job with the mitral valve or the tricuspid valve? And we're honestly not there yet, but the technology is moving so fast. I'm really excited to see we do have a way to completely replace the mitral valve with a catheter-based valve. It's still in clinical trials, and we're fortunate at Inova to be part of one of those clinical trials right now. But I'm very, very excited that over the next 5 to 10 years, we may see a completely transcatheter solution to mitral disease and maybe eventually tricuspid disease.
Okay.
Yeah, I would agree with that. I think the technology is amazing, and it's increasing just at a speed that is almost breathtaking to watch. I mean, so the revolution is going to continue to come into the other valve spaces. The one thing I would add that I think has been one of the great byproducts, at least that I see, especially now that Tavor has moved into kind of the lower risk populations, is I see more patients who were the quote unquote asymptomatics that were probably being held back by the referring physicians for years because you're not quite symptomatic, we're not going to put you through the risk of surgery. But these people are still struggling with kind of a degree of heart failure as an outpatient. I think because of the ease of Tavor, patients who probably should have been getting referred before are now coming our way, and we're helping them lead better lives as a result. So I hope that byproduct carries over as we go into the mitral and tricuspid spaces, just as awareness of valve disease increases, that hopefully people will be getting referred in to see us sooner.
And maybe key takeaways for our audience of what you really think they should remember from this presentation?
Absolutely. I think it's really important to listen to your body and listen to your heart so that if you're ever diagnosed with a heart murmur or diagnosed with a problem like that, you'll know that the important thing is to follow up with your medical professionals. You may be followed for years without the need for an intervention, a surgery, or a transcatheter procedure, but it's still important to follow up because when the time comes, we want to perform that procedure to help you live the best life possible. So it's really important to listen to your body and to maintain annual kind of evaluation with your cardiologist or primary care doctor.
And then I think maybe you could touch on the importance of the decision where to go.
Yeah, absolutely. So, obviously Inova serves the entire Northern Virginia area, and we get patients from West Virginia and Maryland and kind of all over the East Coast. But I think it's really important to choose a place that you have confidence in. And one of the things that I can say about Inova, I would send my family members here, and part of it is that we have excellent cardiovascular surgeons, cardiologists, et cetera, but we also have a very high volume of procedures and a great amount of institutional expertise. So that I do believe we can take care of a patient no matter what they come in with.
Okay, super. Anything to add?
I would echo that. I think with the benefit of having your treatment at Inova is that it's the institutional history here and it's the infrastructure that's been accumulated over time. And so, it's not just the fact that we're able to take care of the routine stuff very, very well. We're also experienced and able to take care of the not so routine things very, very well. And then just to echo Matt's thoughts about kind of just closing thoughts, I think listening to your body, listening to your heart, that's of paramount importance. If you've ever been told you have a heart murmur and you notice that you're feeling sluggish, don't have as much energy, then go see someone. Ask them, could it be my heart? Make sure they listen to it, with a stethoscope. Maybe you'll get an echocardiogram, and as Matt said, maybe that echocardiogram won't show anything, but it's important that it's always that you're at least thinking about it, because we have so many good options for heart valve disease now. It's really a shame for someone to be living with heart failure when they can be helped.
And really a consistently highly ranked heart surgery program for decades.
Yeah.
So, thanks so much for joining us today and for sending in your questions. If we did not get to your question, we'll try to post and answer later. Dr. Sarin and Dr. Sherwood, I want to thank you all for your time and your expertise. If you want to learn more about our structural heart disease program, you can go to inovaheart.org/heart valve, all one word. And if you need assistance in locating a physician, go to inova.org/physicians. Or if you prefer a more old-fashioned mechanism, which I would, then you can call our physician referral service at 1-855-MyInova, which is 1-855-694-6682. Thanks so much, and we look forward to seeing you next time.